Dunahoe, Dr. Dunahoe and Dr. Kweon, I believe. I don't know if Dr. Hagen, you're also going to be joining in the presentation, but this is coming from our wonderful orthopedics department. And we look forward to hearing about what they're doing as far as orthopedic resident surgical skills. The floor is yours.
Thanks so much, Dr. Sweet. I'll just do the introduction for Dr. Dunahoe. She's one of our excellent graduates from our orthopedic program. I'm the program director here, also partners with Dr. Hagen at the Stadium Sports Medicine Clinic here at UWMC. Dr. Dunahoe graduated this past summer and is in the midst of her arthroplasty fellowship at Harvard, Mass General, before she does a trauma fellowship at Washington University in St. Louis. And she's been, through the 5 years that I've known her in the program, a huge advocate for teaching, resident and med student education and outreach. And this project that she's kind of spearheaded with Dr. Hagen and Dr. Kennedy is just a reflection of that. And I'm just really honored to have been a part of the project over this last year and a half or so. So I will, with that, pass that over to Dr. Dunahoe.
Thanks, Dr. Kweon. So like Dr. Kweon said, Jacqueline Dunahoe. So I'm going to be talking about our pilot study of using a low-cost skills module to improve our junior resident orthopedic surgical skills. Myself and my co-authors don't have anything to disclose. So I'll just go over kind of the background for our project, our methods, the preliminary results, and then we'll go through a discussion and then have time for questions. So in today's resident education environment, we're having increasing work hour restrictions, there's increasing patient safety concerns, and then the financial limitations that make training residents in the operating room more and more difficult. And so surgical simulation is becoming more and more important as part of that resident education. There have been there's lots of similar simulators that are available at variable different costs. One simulation that has previously been tested is this Fundamentals of Orthopedic Surgery tool that's previously been validated to show stratification across multiple levels of training. And this is some images from the module, and what they found was that testing with this module showed difference in training level between medical students, junior residents, senior residents, and faculty. Additionally, what they looked at is they put 25 of the medical students through dedicated training, and those medical students improved, and actually their scores on these tasks improved and exceeded those of the junior residents. And so this module was kind of similar to what we built for our low-cost module. So the problem is that in orthopedic surgery skills modules, there's not a lot of studies that track simulations such as the 4s that I just showed you over a long period of time. A lot of them are short-term, showing that they do show a difference between levels of training, but not necessarily over a long period of time. So are these skills, these simulators, helping residents improve their surgical skills over a measurable, sustained way? And so we built some low-cost modules, and our goal was to evaluate the intern skills at the beginning of the year versus at the end of the year, and then also compare the intern surgical skills when they had the module to the cohort or group that did not have the modules. So similar level of training, but they didn't have access to the modules. So what we did is we had 5 separate skills. And I'll go through each of the 5 skills. Our materials ended up costing about $870 to build all 8 modules. There was some additional costs for the depth gauges. We did get some donated, as well as the old striker drills that were donated by University of Washington Hospital that were added to our module. So this is what the module set looked like. This is all of the tools that the residents had access to and were sent home with. So the first module was depth of drill plunge. The purpose of this module is really, when you're drilling for screw placement in plates or placing K-wires, the goal is to not plunge into the soft tissues behind the bone. And so this PVC pipe in a kind of unstable structure was meant to model bone as it might be in soft and tissues. And we wanted to measure how far the residents were drilling past the second cortex of the bone. So you can see in this bone block, the holes, which are the plunging of the drill past the second cortex of this bone. Another module is using the depth gauge. This is a tool that we use to measure the depth or length of the hole that was drilled across the bone. And this can be very difficult and frustrating. And I've watched myself as a junior resident and even now struggle to accurately measure these holes. The other module was placement of the screws. So placing the screws in with good technique across the hole, staying collinear with the screw head into the screw. That was the goal of this module. And then angle drilling. And so the purpose of this module is in all the other drilling modules, they were drilling perpendicular at 90 degrees to the bone. And that's not always how we're drilling or placing K-wires across the bone. And so the purpose of this was practicing and testing how to start a drill at an angle to a rounded surface and doing that without slipping, and then also hitting your trajectory point. So they were starting at one point in this area and then trying to reach a different point across the bone. And so not just being able to drill straight across a bone, but also make a trajectory with their drill and be accurate. And then this module is a fluoroscopic simulation module. The idea behind this is a lot of times when we're placing screws or K-wires in the operating room, we're using fluoro to help guide the trajectory of our drill. And so the idea of this is that the resident can see the points A, B, or C, which are their starting points. And then they can only view one side of this block from at a time, like a fluoro shot. So you can view your AP and then you can view your lateral. And these lines indicate where point A on the opposite side of the bone is. And so their goal is to drill from the one side that they can see the lines showing the trajectory and hit the dot on the other side. And so this is an example. You can see the drill hole here compared to the goal mark. So we had 8 PGY1 residents, interns that were started at the beginning of the academic year. And then we had 8 PGY2 residents who had just finished their intern year that were the control group because they had not had access to the module or used the module previously. And then each of the intern group took the module set home, including the drill, depth gauge, screws, and some additional materials so that they could practice with these modules at home. And then those interns that had the modules were tested again at the end of the year. And so what we did for our testing is we had 2 faculty observers that rated the measurements, rated the residents on using the tools, using this the objective structures assessment of technical skills, which is a global rating scale that's previously been validated. And it's also called for short the OSATs. And then we also measured time for task completion and then accuracy. So for the trajectory measures, how far away from the trajectory goal point did they make errors such as slipping off the screw, slipping off the bone with the drill, starting and having to restart, starting or stopping the drill, were also all recorded. And then we also asked the residents, the interns that were using the modules, to provide feedback on the modules and how much they were using them throughout their intern year. So this is the global rating scale that's can be used to evaluate residents in the operating room. And it's just a rating scale for surgical technique. And so we focused on 2 specific portions of this, the time and motion, as well as the instrument handling. The other ones, the soft tissue, flow of operation and use of assistance, just weren't being tested in our module. So we focused on using this global rating for time and motion, and then instrument handling. So a 1 would be a low score. So in the time and motion, they're taking a long time, and then they're also using a lot of extra movements to achieve their goal, versus a 5 would be a skilled surgeon who can very efficiently place the drill, for example, at the start point, and doesn't have to make a lot of corrective movements. And then instrument handling, such as with the depth gauge, just the finesse of being able to use that easily and smoothly and not doing it in an awkward position that may make it more difficult. And then this is what our resident survey looked like. One of the questions we were asking is, how confident they felt in their overall skills prior to the test. So, using a power drill, using a depth gauge, placing screws, and then the triangulation skill in the fluoroscopic module. They were asked to complete this survey both at the beginning of the year before the first test, as well as at the end of the year before their second test. We also asked them to evaluate the overall module and whether or not what they thought if it was useful. Did they think it was going to enhance their orthopedic training? Did they think it was going to enhance patient safety? And then if they thought it should be part of the orthopedic surgical education curriculum. So we used the OSAT scores, and we compared the PGY1s at the beginning of the year versus their end of their year. We also compared the interns at the start of their year before they've had any training to the PGY2s who had just finished their intern year. And then comparing the PGY1s or interns at the end of their year to the control group PGY2 group. So they're the same level in theory. They've both completed 1 year of residency. And then we also evaluated the reliabilities for the faculty observers' Oats scores. And then we used paired t-tests for the compare the residents themselves and then also to the PGY2s over time for those objective measures, such as how long to complete the task and their accuracy. So what we found looking at the PGY1s at the beginning of the year versus how they performed at the end of the year in the OSAT score, maximum score was a score of 10. At the beginning of the year, they were 4 to 6 on all of the skills. And then at the end of the year, they were ranging between 8 and 9. And these were all statistically significant improvements in their overall rating of performing the 5 tests. So then looking at the PGY1s at the beginning of the year, before they've had training, to the control group, the PGY2s that had completed 1 year of residency. And what we found is that their scores were actually fairly similar, except for an angled drilling. The rising PGY2s were statistically significant, better according to Oats than the new PGY1s at the beginning of their year. Otherwise, they were fairly similar. And then comparing the PGY1s at the end of the year that had used the module for the year, and then the control group, the PGY2s that had not had the module during their PGY 1 year, we found that the PGY1s at the end of the year scored significantly better on all the modules using the Oats scoring compared to the group that had been tested at the end of their intern year that had not had access to the modules. And then as far as our inter-rater reliability for the Oats scores, for the PGY1 scores, it was moderate to good. And then for the PGY2 scores, it was moderate. And then for the objective data, so their task efficiency as far as time to perform the tasks, they were, and comparing the beginning of the year compared to the end of the year, they significantly improved in their angled drilling time or task efficiency. Otherwise, they were fairly similar in all the other tasks. As far as task accuracy, they were fairly similar in all the tasks except for plunge difference from the beginning of the year to the end of the year. And this is again the group that had the modules. They significantly improved in their plunge distance, how far they plunged past that second cortex by the end of the year. And then comparing their task efficiency for the PGY1 group at the end of their year that had the modules versus the control group, the group that had the modules at the end of their intern year was more efficient as far as taking less time to perform the plunge, depth gauge use, and then angled drilling. Their screw placement and the fluoroscopy tasks were fairly similar between the two groups. And again, looking at their task accuracy, these were actually fairly similar for the PGY1s at the end of their year compared to the control group, the rising PGY2 group. And then looking at the resident self-surveys, the beginning of the year interns towards the end of the year interns, there wasn't any statistical significance between their confidence in performing any of these tasks. And these did have very large standard deviations, but none of them were statistically significant. And so the self-confidence of the residents at the end of their PGY 1 year, the ones that had the modules versus the control group, again, they had similar scores and no statistical significance between the two groups. So for our post-module survey, with whether or not they were satisfied, they were all overall very satisfied with the module. They, for the most part, felt that their training was enhanced by using these modules. And then they felt like it may enhance their patient safety in the operating room. And they also overall felt that it should be part of the intern curriculum as part of the orthopedic surgery training. As far as how much they had used the modules throughout the year, they varying amounts of use. So they reported 0 hours to 52 hours as a range. On average, it's about 10.6 hours, and the median was 6 hours. Those that reported that they didn't use the modules throughout the year cited that they had difficulties with the drill not working, but didn't actually contact any of us to let us know so that we could get them another drill. And there may also be recall bias in this. We were asking them at the end of the year to report about how many hours they thought they were using this module. So overall, what we found with the low cost skills module is that their performance enhanced from the beginning of the year to the end of the year. And the class that had the module during the year did perform better on the Oats scores compared to the class that didn't have the access to modules at home. And this was even with some residents not using the modules at all during the year. So the Oats data has some, it's the objective data, the measure of the time efficacy and the accuracy does agree to some extent with the Oats data. And overall, the residents liked the modules, but they, even though they didn't necessarily use them that much, some of them did. And then, the limitations of our studies, there was a huge variation in how much the residents use the modules. So are these results really a representation of the use of the modules, or is it something else? Additionally, is there a difference between the two classes and the two groups? So, did the group that had the module have better OR access or different OR exposure than their group before? They all did the same rotations at the same hospitals. Our curriculums didn't change between the 2 years, but maybe they just had a difference in experience. Perhaps the group is overall better learners. The other question is, did the testing at the beginning of the year help the interns recognize their limitations and the importance of some skills that, in the operating room, so that then when they were given the opportunity to operate, did they pay more attention to developing those surgical skills and using those instruments compared to the group that didn't have the test at the beginning of their year? So we can't really account for either of those. So thanks for joining us. I'm happy to take any questions, and then if anybody has any.
That's excellent, Jackie. Thank you so much. Are there any questions?
I have a question.
Dr. Pellegrini.
Well, I have a couple of questions. The first one is, how much of a reflection of what will happen in the operating room is this simulator? For example, do you have attendings, and do you have numbers on how attendings perform? If you have, that would give you some parameter that you can compare with. Because I'm stricken by the fact that the second year residents, the starting second year residents, who presumably didn't have the simulation, seem to perform less. Well, does that mean that they have less skills in terms of orthopedic surgery, and therefore the year that they spent before, they didn't learn enough technique? Or is it something that they just don't know how to use the simulator? And if we have data from a PGY 4 or 5 or a faculty member, then that will give you some idea.
Yeah, so we don't have that data as far as stratification cost training levels for this simulator, but our simulator is very similar to the FORS simulator that has shown stratification. And so that simulator very similar modules did have, and it's what our simulator is kind of based off of, is that model, did have significant difference between, medical students, junior residents, senior residents, and attendings. But that is something that we were considering continuing our research on, looking at how this module performs across training levels. Because I agree that is a limitation.
Okay, do you also have any way to look at the time used on the simulator versus the results obtained? Because there was a variation from 0 to 50 hours of use. And I wonder if more use of the simulator yielded a better result or not.
We do have the ability to evaluate that, but we haven't looked at the data in that way.
Yeah, these are great questions and comments. I think nice job, Jackie, on that. We still have some more analysis to do. One of our targets, and this was outlined in our initial grant too, is that we do want to test it across different levels of training and have that data to compare to like how a faculty or how a senior resident would do, just to further validate what has previously been shown on these modules, that with the reference that Jackie gave. And then the second question, our sample size is so small. We will do a kind of a very like linear analysis graph of showing of how module use corresponded with change in OSAT scoring. But I don't know how much we'll be able to get out of that, given, we only have 8 residents. But great question and great thought.
Yes. So Jackie, yeah, great job on the presentation overall, and just great amount of work. So really commend you for doing this with Dr. Hagen and Dr. Kweon. So kind of along the lines of Dr. Pellegrini's questions, just looking at the direct correlation between amount of time on the simulator versus their performance. You kind of mentioned some of the discussion points. You're testing beginning of the year towards the end of the year, were these skills acquired throughout the year versus simulator. So I think it'd be great to have this as part of Monday morning conference, maybe 1 hour per week. You kind of test the beginning of the 6-week module versus the end of the 6-week module, see if there's a direct correlation there. And also just have the stratification across the group as far as junior residents, senior residents, also faculty, really showing kind of fidelity of this, really truly testing surgical skills. You mentioned the first years and second years, there might be some innate ability differences between the two groups as far as the 2 classes. That's why the second years who didn't have access to modules maybe score lower, but it may not be because of the modules. That might be some differences between the 2 groups.
Yeah, thanks, Dr. Wong.
Yeah, great presentation. I wanted to just add to that by saying that I wonder if it's possible, and I assume that the residents track their procedures to get a sense of, the different years and what kind of exposure they had in the OR.
Yeah, that's a great thought. They do track their case. They do keep track of their case logs and what procedures they do or are part of.
Mm-hmm. And the other suggestion I had was this would be a great submission for thinking IMSH. Every year there's a call for proposals or abstracts for these types of simulators, and I think this would be a great fit. I was really intrigued by how simple and yet thoughtful the whole exercise was, and how again, I'm not a surgeon, but it certainly looks really applicable to practice.
Thanks. We'll take that.
Jackie, I've got a question, but I don't know if you have the answer to it because it's a stats question. So are you comfortable answering a stats question?
Not great at stats questions.
Okay. I would suggest, well, really the question is the rationale for using multiple t-tests rather than using a more elaborate inferential statistical test like an ANOVA or something like that. I just have a little concern when somebody presents a lot of t-tests, there's the opportunity for increased likelihood of a false positive. So I just want to suggest that maybe you might want to check these just as far as what the results would yield in an ANOVA situation, just because the more t-tests you run, the more likely it is you'll find something that's really not there. So just checking that out. Mind you, given the fact that we're only dealing with a sample size of 8, statistics obviously have to be taken with a grain of salt here too.
Yeah.
Yeah, thanks for that comment. These stats are done pretty quickly since we just finished up our data collection in and out. So, we're definitely going to double check a lot of this. And I think an ANOVA is a great idea. I think, using a bond for error correction is another opportunity because exactly what you said kind of becomes a fishing expedition with multiple comparisons. So thank you.
Totally. And one more thing on the stats stuff. You presented a scale information as far as like what if they liked it and stuff. Was that done on like a Likert scale, or like I think it was presented as means with standard deviation? I'm just curious as how that data was collected.
Go ahead, Dr. Hagen.
Sorry, it was basically just like if Jackie, I don't know if you have that slide, but it was like a sliding scale 0 to 100, and they put a hash mark, where they
visual analog. Okay.
But yeah, exactly. Yeah.
Okay, that's cool. Just because I was a little concerned, it's like if it's Likert, really we should be using a non-parametric test here.
Totally.
So,
yeah.
Cool. Great presentation, Jackie. Thank you very much.
Thanks.
Jackie had a couple of questions. One in general, which is, how did you choose the procedures specifically that you're going to include in this? Was this something that is defined at a national level, and then you built the curriculum around that, or did you have a group of educators come together and say, these are the skills that are really, quote, fundamental for orthopedics? And then my follow-up question after that really is kind of along the same lines of what Rachel was saying, which is, simply correlating those skills that you choose then to an actual performance in the OR. Just as what Dr. Pellegrini was pointing out, it could just be that they had more exposure to the simulator, which made them better. And it may not correlate. You got to correlate it to how they perform either objectively or subjectively in the OR, which you guys probably do anyways, right? So you could have a similar OSATs when they're drilling in the OR or when they're placing, screws or wires or whatever.
Yeah. Thanks. So for your first question, as far as developing what skills we were going to module, it was based on kind of the skills that a lot of interns get the opportunity to do in the operating room, but often don't have a lot of exposure. So not everybody has, used a drill before, placed a screw before, whether it's in the operating room or outside of the operating room, just using those tools. And almost no one's used a depth gauge before. And it was actually based off, we had done kind of a similar skills competition when I was a medical student at University of Washington, that we did some of these kind of similar modules. And so they were skills that are skills that we observe in the operating room, as well as ones that can be tested. And then additionally, in just looking at, what simulators were out there in resident education, I was looking for ones that focus on intern skills. So skills that interns are trying to develop in those first years, which is, develop use of tools in these basic ways. And a lot of the kind of research that I had looked at and like the ABOS resident curriculum, our board curriculum for interns, focuses around drilling, use of drill, depth gauge, and the technique of doing those things and performing those in the operating room. So that was kind of how I chose the skills to include the module. It was just based on the literature I'd seen, as well as experience being a junior resident. As far as your—
Before you go, is it your goal to make this really focused here at University of Washington, or is your goal to have this then basically spread and become more, even potentially a national standard or global standard, something like, FLS has done, and some of the other curricula that go kind of more broadly? Is that your goal for this?
Yeah, I think it'd be great for it to spread. The whole idea behind it is trying to learn these skills that you could maybe learn outside the operating room in an easy, cheap way for programs, so that programs that, in our financial restrictions of residency programs, would be able to afford these modules for their residents. So that was one of the goals. But I think in reference to your second question, before that could really be adapted across other programs, or where you could really push for that, we would need to show that the skills in the module translate to the operating room in the Oats scores, as you mentioned. That is something that we want to do in the future, is look at, the scores on the modules versus in the operating room? Because like you said, did they just get better at doing the module over the year?
Because you're watching with FLS and a lot of these other curricula, sometimes some fantastic simulators and curricula get built at these institutions. They never make it out. And the reason isn't because it isn't good. It's because it wasn't invented or thought of by this group. Politically, it's a good idea once you get enough data to then take it, but going with a fresh mind and say, okay, now, I don't know, Board of Orthopedics or whoever, take a look at this. How would you, what skills are you interested? What skills do you think there should be in here? And let them kind of recreate it, I guess, because then it's more likely to then get adopted if you have some solid data.
I wanted to, I just wanted to pitch in on just that the concept or that topic you bring up about fidelity. I think everyone here that's interested in simulation and getting reps outside of the on live patients is concerned about whether that exercise really translates into becoming that better surgeon or technician or clinician, that crossover, that fidelity. And in my experience, we've used an arthroscopy simulator similar to the laparoscopic simulator that's in the Wish lab, and we house it on the 10th floor at UW for our interns. That's part of their intern and second year curriculum, on sports anyway. And my anecdotal experience has been, it's not that there's high fidelity in any of these simulators or any of these modules or exercises, but I feel like there's a really tight correlation to people who take advantage of what is given to them to feel more comfortable doing XYZ activity, even if there isn't high fidelity, or the person who, when tasked with something, takes that job serious enough to put in a few hours, do it ahead of time, reinforce the moves or the behavior outside of the actual time in front of the patient, which is so limited and restricted by ACGME work hours. And that correlates, like that's a tight correlation. The people that kind of are wired that way tend to be the people that are more diligent in other ways. And so even though there's not this direct fidelity with the clinical surgical skill on the live patient, there's this fidelity with behavior almost more than the actual thing that we have them practice. And I don't know how to measure that. Like, I don't know how to tee up these future simulation or models to try to really leverage that part of it in our learners.
Chris.
Yeah, looks like a really great module, very productive. I'm an engineer, not a surgeon, so my drilling into bone is limited to what we've gotten from a butcher shop, and the challenge there was really trying to hold it in place, not so much, the feel of the bone. I've drilled into a lot of PVC, and that's definitely what I would have chosen for the model too. If you think that there is enough difference between the feel, I'm running an undergraduate design course this coming fall, and I would be glad to throw in as one of their project options a higher fidelity tube or pipe or multi-layer, whatever you think might be appropriate there. So if you'd like to, I'd be glad to talk about that option.
Yeah.
Now that's recorded, Chris. We've got that your commitment.
I know that, Aaron and I think Dr. Kennedy had worked on maybe some other modules, and they might actually be very interested in that because they've been working on developing other types of materials. For this project, the goal was something simple where all the materials could be bought at a hardware store so that it was easily reproducible at other places that maybe didn't have the technology to, 3D print or develop some other module. But yeah, that would be really interesting.
Absolutely. Okay, great.
Jackie, was there some training that was going on too? Obviously, if you take a room, you take a bunch of golf clubs and you stick it in a room and say, go work on it, you may want a bunch of residents with a really bad golf swing. That then they just reinforce that, then it's hard to unlearn that. Was there the proper teaching of technique as part of the training of these particular skill sets?
So there wasn't any particular proper technique training that we included as part of their modules. They did get that when they're in the operating room and operating, the idea is they're getting that feedback on just how they're operating in the operating room, but we didn't include that as far as here's how to perform well on this module or this specific skill. There are a lot of training videos that like the American Board of Orthopedic Surgery has produced some, as well as some from the Hand Society. Those types of videos are available that kind of talk about how to do some of these skills.
There was some light feedback provided to both groups of residents after the first round of testing at the beginning of the year when we noticed, some incorrect technique. But yeah, nothing formal, as Jackie said.
That might be something to add to it, right? Whether it's in person here and there, or actually have some modules that, okay, now once they're done testing, when they're doing the training aspects, they're pre-testing, then actually show them the proper technique. So they're reinforcing good technique over when they're doing their reps.
Yeah, thank you.
Other questions, comments? Jason, I was wondering, do you have the C-arm? I was looking at this and I wondered, I don't know if you guys have seen, there's a C-arm trainer that we built back in Minnesota for urology that I could see helping with your fluoro. Jason, I don't know, do you have that? Could you show it potentially and see if that's of interest?
I do. I've got some photos handy. I may need to share the screen. There we go. Thank you.
So the idea with this is you put your model, whatever it might be that you're teaching for triangulation, in this space. And there's a camera that's up on top, and then so you can actually see through this particular media, and then you can drill or do something, but you're looking at a two-dimensional, which looks like it's a black and white filter. So everything looks black and white. And so in this case, we're gaining percutaneous access to the kidney, practicing, maneuvers of rainbowing and tilting of the C-arm to triangulate and find the exact spot that you want to place your puncture. I'm wondering if this is something you could do when you're putting your screws in for your fluoro exercise.
Yeah, that's really great. I mean, the other application that I see for this as far as orthopedic surgery is, our interns, we're trying to get specific views of, like an ankle or a hand. And that's always a struggle for junior residents, is trying to how do you arrange the C-arm to get the view that you need? So sometimes they know what the good view is, but trying to get it is difficult. So this is really, really cool. And
obviously it doesn't use any fluoro, which is nice too. So you're not getting exposed to x-rays during training, which has always drove me nuts. But yeah, just a thought. So maybe set up some time with Jason afterwards to look at this and see if there's some possibility to do that or use this.
Wanted to also add that for maybe another twist, by the way, that was super cool. You could consider some telesimulation, just piggybacking on the thought that, residents might need some additional suggestions about their technique. Would this be something that could be done remotely? So given that they have these kits at home, could they connect to an instructor and get some feedback or advice on how to proceed, and would that potentially change outcomes?
Yeah, I mean, that's really interesting. We hadn't considered, doing feedback with the sessions. Some of the residents had requested it being available in the resident room where they'd have, senior residents that might also be able to give that feedback, but that's a really good thought.
Wonderful. Any other comments or questions for for Jackie or the team? All right, I have a couple of other quick announcements that I forgot. Megan reminded me. The Wish Innovations Award is available for another round through a generous donation by a donor. There'll be $20,000 of funding available for potentially multiple awards. It sort of depends. The deadline is October 29th. Megan Sherman, reach out to her if you're interested in applying for one of these awards. These types of projects, I think, are perfect for that type of amount to start developing new simulation curricula and models. So that's one announcement. And anything else anyone wanted to bring up? All right, Megan, what do we have on?
I have two things that I wanted to say to you. One, Rob, is I am amazed at the number of people that are joining now. This used to be a group that were 4 or 5 at the very beginning, interested parties. And I see that we had 32 participants a little bit earlier. Some are dropping. And the second thing is, when you were showing all this positioning and all these other things that you use in urology, is the great advantage that Wish brings to the community of people that are developing